Our first question is, what is the BHU, the Behavioral Health Unit, and what is CIT, and what does it mean for an officer to be CIT trained?
So just to introduce myself, Officer Kearns, Newcastle County Police. I'm assigned to the Behavioral Health Unit. My partner is actually a social worker, Delilah Colon. She's has her MSW, was an intern with us, and then came on full time. So she's a licensed MSW that rides with me every time I'm working. She's working, and we respond to 911 calls. So the Behavioral Health Unit as a whole has two sides. We have an addiction side, where if anybody in Newcastle County Police jurisdiction overdose within 48 hours, a nurse and an officer and sometimes a mental health worker will be at their door offering them services for treatment. So we kind of pitch it to them like, hey, you overdosed and you died 2 days ago within the last 2 days. We're here free of charge to help support you in getting sober and getting into treatment. So that's the one side. And also part of that is if an officer stops somebody and their charges are related to drug use, so there's like real no victim. So it wouldn't be domestic or assaults or anything like that. The officer has the ability to offer that person the Hero Help program in lieu of arrest. So instead of going to see a judge, they can go see a counselor and they can go to detox. And then our case manager will follow up with them. And if they do have other pending charges, as long as they're in treatment, and we don't set what the treatment guidelines are, we turn that to the professional. So whoever they're working with, whether it's RCI, NET, as long as they say that they're compliant with treatment, we'll send a letter of support with them to court saying they've been with the Hero Help program for X amount of days, they're doing well in the program, and kind of advocate on their behalf. Because the last thing you want to see is a person get to a good point and have a court case derail them from being sober, whether if it going them having charges that they got to pay off or just interrupting their treatment. So we will support them the best we can in advocating with the courts for them. So the second side is the Behavioral Health Unit. So there's two teams. So it's myself and Delilah, and then it's Officer Amari George and Adam Smiley. Adam Smiley is the social worker that works with Officer George. So we work 4 days on and 4 days off. We start at 9 o'clock in the morning to 8 p.m. at night. Our goal is eventually to have 4 to 5 teams, but right now we have 2. And then we're supported by a case manager. So she does all the follow-up. So once we go out to somebody, like you saw, and we de-escalate them and we get them into treatment, Jess follows up and how's the treatment going? Did you understand your discharge planning? And if they're not getting to their treatment that was set up, why? And is there barriers that we can help break down? Is it transportation? Is it childcare? That kind of things. And then we support the families. We refer families a lot to NAMI family support groups so that they understand what's going on. We went into a house one time and the family's like, hey, my loved one is schizoaffective. And we're like, okay, cool. We go in and we talk to them. And then I asked the mom, I said, what does schizoaffective mean? She had no idea. So she knew what her loved one was diagnosed with, but had no idea what that diagnosis meant. So we contacted NAMI, and Jen and her team actually reached out to her and spoke to her and really helped the family member understand what was going on with their loved one. So that's kind of what our team does. The CIT program is completely different. It's we offer at Newcastle County for anyone that's been an officer for at least 3 years. So we want people to understand what it means to be an officer, what it's like to respond out. And NAMI puts it on, and it's a statewide program. Any police officer in Delaware can go to this training. 40 hours of intense mental health training. So how to de-escalate, what is mental health, what's it look like? suicidal assessment, role playing. So it's a 1 week that these officers are trained. And at the end, we do roll calling, we do scenarios where they get to put on headphones and hear voices and try to do simple tasks like a job interview or a doctor's office. So they get to feel what it's like to have someone rapidly ask you questions while you're hearing voices and try to answer. So NAMI puts on a great program that we support at Newcastle. And then we have about 50 people currently CIT trained. We try to make sure that every unit has somebody that's CIT trained or a few people that are CIT trained, from our patrol squads, our detectives, to our drug unit. So, because everybody is going to run into someone that is experiencing some kind of crisis. So having somebody in every unit really is an added tool to de-escalation out in the community. So what was did I miss anything?
I was just about to ask if Delilah wanted to add anything about her role in the BHU.
So my name is Delilah Colon. I'm partnered up with Colleen, like she said. And one of the things that's very important for us when we're responding is that we're both connected, we're both present. And any calls that we're receiving from the 911 dispatch, that we are receiving the information and we know what we are coming into. And then engaging. I think connection is very, very important when we are working with the citizens in the community. And if Colleen, who presents herself first to the individual, develops that connection, she leads. If for whatever reason that person says, I don't want to talk to a police officer, that's when I step in. So that connection that is displayed in the clip is very important when we're out engaging with anyone in the community. Gathering as much information that if that individual had been connected to care or is connected to care, that we re-engagement back to that care so that they can start receiving the supports that they need. And then of course, like Officer Colleen said, we'll get our case manager to do the follow-up to make sure that they're following the treatment plan that's in place for them.
So I see a question in the chat about autism. We do have an autism awareness training that every officer receives in the academy. So we're not asking them to be able to diagnose somebody with autism, but we do train them to knowing what signs and symptoms and behaviors that this person might be autistic, and how to interact with them more appropriately. We are this year, the behavioral health unit will be attending first aid and mental health training. And then we're going to be bringing that to Newcastle County Police Department as a whole in the next year or two.
And that kind of leads into one of the questions that I had on our sheet, which is, are there any other law enforcement initiatives that help individuals with mental health conditions and their families? Is there anything else similar to that that maybe the community would or should like to know about?
So both the in our Newcastle County Police Department, I'm going to speak for us because we started this unit about 2017 and brought both the addiction and the mental health team together. We have been talking to police departments across the state and how can they start a similar program. So I know that Dover and a couple lower township, Delaware is working on bringing this to their police departments, but it is a funding issue. It does take a lot of money to get it started. We were lucky that we were able to receive grants. We're still a grant funded program. We're not hard funded, so we depend on grants for this unit to be up and running. And we partner with Christiana Care because merging police officers and social workers was very interesting. Time is interesting. Like police officers show up 15 minutes early. And our first meeting when we started, we met with connections and we walked in 15 minutes early and we were waiting another 20 minutes for people to show up. So merging the two worlds have been interesting. And I joke with my social workers all the time, like, hey, our meeting's at police time, not social worker time. So let's be on time. And they give it to us right back. So, I mean, it is definitely it was a growing road that we had to go together. And even just talking, the first email I received from our social workers said F/U on it. And I was like, why is this social worker already cursing at me? We just met yesterday. Had no idea that she was talking about a follow-up. So, and we speak in 10 code. So I have to help them learn how to speak police officer. So when we walk in to a house and someone is going to be arrested, we would just say like, hey, it's 15, knowing that 10:15 means that the person's arrested. The social workers had no clue what we were talking about. So we had to take a step back, do some kind of cross training so that we speak their language, they speak our language. So a lot of times we were saying the same thing in two different ways and we're getting frustrated with each other because I was like, why don't they get it? And they're like, well, why don't I get it? I do have my MSW from University of Penn. I received that a couple of years back. I'm a little bit older. So I do my best at trying to help us speak the same language and understand why things are happening in the police side and then help our police officers understand what's happening in the social work side. Because a lot of times we assume things that are not true. Like we assume that some of the providers out there, why are they transporting their clients? Well, they can't because of their procedures. And just because it says you went to one connections house and they could transport, doesn't mean the next house can, and that there's different levels of care. So I try to do a lot of sharing information so we're all on the same page. And I work with me and Delilah and Adam and Omari will go out to providers and cross-train, like, hey, this is the roles and responsibilities of the police department. What does your program provide and what are your roles and responsibilities? Like, what should we expect? Because a lot of times we'll get like a 911 call and we'll go out to a group home and they turn around and look at us for the next steps. So we're pushing back to a lot of the providers being like, this should be a team effort. You shouldn't just call us to your group homes or to your client and expect the police to know what to do next. So we are doing the cross trainings to, hey, you should have a crisis plan. We should be involved in your crisis plan, but it should be together. And I push back on a lot of the providers like, hey, it might not be safe for you to transport, but I need you to meet me at the hospital to help check in your person. Because if you know them, you know how to keep them calm. We can work this together to keep the person as safe as possible during this crisis. I probably went on a little tangent there, but I know watching them de-escalate that woman that's about to jump happens a lot to us, like someone in that heat of a crisis, and we finally de-escalate them. And I'm on the same page of Ernie and them, like my job's a little different. So if I get to a house and I'm there for 11 hours, I'm there for 11 hours. I am there until the crisis is de-escalated safely, as safe as possible. And they're connected to the right care. And I don't care if it takes me 5-6 hours. What I do care is that as soon as I get that person in my car and we get them transported, that when we get to whatever hospital, that they're received well there. We have gone places and right away, as soon as we walk in, they're like, oh no, we don't want that person. And I'm like, whoa, time out. If we are not at the right place, can we at least say hello and introduce yourself to the person I brought in and point us in the right direction of where we need to go? So if we're not supposed to be at your hospital, where are we supposed to be? Because I just de-escalated that person for hours. And then we got to the provider and the provider's like, nope, you go somewhere else. And now I got to refocus that person and accepting help somewhere else. So yeah, it's tough. We try to bring My goal is I don't want to bring everyone to an ER, because if they're in a mental health crisis or if they're in addiction crisis, if they don't need medical treatment, then why do they need to sit there for 5 hours to go somewhere else? If we can get them to the right place at that time and cut how many times they have to tell their story over and over and get them the right treatment, that the next time that they're in a crisis, they would feel like it went well when they called the cops, and the cops came out here and treated them with respect and helped them get the right help, that they'll call us again. Or maybe they'll call sooner, and maybe they will call our case manager or our social worker and say, and it has happened in the last year, like, I feel like it's happening again. I need help before I get to that point. So that's why I say when I get to the place and I'm talking to the provider, if we're not at the right place, I just ask them to at least say hello to my client and explain why we're not going in and why we're going to a different hospital. So that person just doesn't feel like they're passed around, that they're actually being seen and heard.
Thank you so much. Is there anything that you wanted to add, Delilah?
I think one of the important things, as Colleen was just saying, is just to make sure that we stay with that individual for as long as needed and just get them connected to the care that they need. It's important for the individuals that we're working for to understand that there's help out here and that they're not alone, and that they can get the supports that they need in the community. And you know, it's about patience, and it's meeting them where they are and understanding that right now they're not well. And in order to get them well, patience is definitely needed at all times.
And I will say what Delilah and the social work team is amazing at doing is following up with that client that said no. So they weren't a danger to themselves or others. They didn't want treatment at their time, but we can see that they're in a crisis. The team of social workers that we have is relentless. They will call and chit chat and talk and hear the same stories over and over again just to make that connection. And we had somebody that took 13 interactions until that person said, yes, I'll go in for assessment, but just an assessment. So I do want to shout out to my social work team there.
So I think at this point, we're going to end the recording so that we can take some of the questions from the audience. So thank you for this portion.
So I say the